thank Dr. Chamberlain and the Data 2 Foundation for giving me the possibility to present this data and to invite me to this beautiful Congress. So in the next 15 minutes, I will give you some, well, I will try to face with you the burning question of the carriers in this ADA2 deficiency. And well, I think, as I told you, I will have more questions than answers. Anyway, I will start from real data. I want to present you the story of this family and to describe the clinical phenotype and laboratory characteristic of two relatives, that is a proband and his mother, and a heterozygous son. So actually this patient that you can see here is our proband, was referred to us from the immunological center of another Italian Rome, another hospital in Rome that was Policlinico Umberto I, because of suspected autoinflammatory diseases. Actually, this proband turned out to be homozygous for a biallelic ADA2 mutation. And this is the pedigree of the family. As you can see, the mother was resulted to be to carry two mutations as well, while the father was heterozygous. And then there is, and I will come back to this in a while, another child that actually died at the age of 12 for an hyperinflammatory syndrome. So this is the pedigree. As I told you, we didn't have the chance to analyze the genotype of the relatives of the father, so the father side of the family, but you can see there are some carriers in the mother side. So the died guy has actually a partially overlapping symptomatology with the proband and his homozygous mother. So well, we'll see it. Okay, so let's concentrate on the right bottom corner of the slide, and this is our proband. And as you can see, he is a 17-year-old guy that was previously healthy, actually, till the age of 16. Really, in the past medical history, he refers some oral ulcers and some episodes of abdominal pain, but were very mild. And actually, the lab test displays some low levels of IgM and IgA. But apart from this, he was absolutely fine. So we started with at the age of 16, where he had a fever, a strange fever, just in the serotype. So it was in the evening with some arthralgia and a specific rash. Then after this first episode, he started having a recurrent episode of fever lasting almost 10 days and 10-15 days apart, one episode to the other. So he came to the other hospital, he was admitted, and actually at that time, he was pretty fine. No fever, no livedo rash, no inflammatory marks, so he was fine. But he has this history. And in the family history, there was something else, because the mother, you can see here, actually, that turned out to be homozygous as well, was fine till the 30s, when after her first pregnancies, she developed a chronic pericarditis. It was pericarditis, not pleuritis. And, but apart from this, it was pretty fine. And she developed in the 40s some degree of hypogammaglobulinemia, but it was mild. And we met her when she was 51. So this was the history. And when we made the diagnosis of the son, of course, we test the mother, and she resulted to be homozygous. So we proposed her to start the therapy, of course, but she refused, and she refused even to perform the MRI, because we proposed the MRI because in the past history she had a couple of episodes of diplopia, even if with a negative normal CNS MRI findings. So at the beginning she refused, but after 1 year she actually developed a more severe phenotype with recurrent fever, the hypogammaglobulinemia worsened actually, and she had pericarditis, persistent pericarditis, and generalized lymphadenopathy. So she first was treated with intravenous glucocorticoids and colchicine, and then we were able to convince her to start adalimumab. So she started TNF inhibition. But then there was another thing, strange things in the family, that is this heterozygous son. He turned out to be heterozygous post-mortem, of course, and he actually was admitted, he was previously healthy, he actually was admitted to the hospital with a clinical picture characterized by fever, rash, and pleuropericarditis. So as soon as he was admitted, they of course did perform several analyses, microbiological analysis, and several others, and everything turned out to be negative. But soon after the admission to the hospital, actually he worsened, and he developed like a dress-like syndrome with hypereosinophilia, and he even performed some biopsy, skin biopsy, lymph node biopsy, and bone marrow biopsy that actually exclude any lymphoma or any other malignancies in this patient. So this is the story. Then we have another carrier that is the father that was actually asymptomatic. This is the lab of the patient. It's a busy slide, but I want just to focus on all of the patients had a really mild elevation of acute phase reactant. You can see the CRP here, particularly even in the mother who was homozygous. It was slightly higher in the proband and in the dyad brothers, but anyway, what was common to them was a mild hypogammaglobulinemia. So after diagnosis, there were tests for enzymatic activity and actually resulted very low in the proband and the homozygous mother, while it was in the carrier range in the father. Unfortunately, we were not able to perform the enzymatic activity in the dyad brother because the sample was not good enough. But anyway, either we couldn't perform more deeper genetic analysis. But anyway, so our data confirm that there is a wide range of phenotypic variability between DADA2 patients regarding age of onset, severity of end organ involvement, even within the same family and among patients with the same mutation. So the search for ADA2 mutation and the assessment of ADA2 activity should be considered even in patients without an inflammatory phenotype, but maybe with the association of hypogammaglobulinemia and well, they had some inflammatory phenotype, but not the livedo or other manifestation of the disease, and with late presentation in the absence of vasculitis. So the clinical picture of the disease carrier poses question of the possible clinical relevance of the heterozygous pathogenic variant. Of course, we cannot say it was the cause, I assure you, but maybe it may somehow contribute. Amanda yesterday said that they might be in a kind of balance and maybe some exogenous factor may precipitate the situation. We don't know actually if it is possible. Anyway, what we know from the literature is that there are several patients with heterozygous patients described with that are clinically symptomatic. This is a paper from the Gaslini Institute in which they found these two brothers with vasculitic phenotypic, with livedos, other vasculitis manifestation, and abdominal pain and diarrhea. And actually, they did find only one mutation. Then there is this other paper, there are several, but I just reported two, with even more severe phenotype, with actually several strokes reported, both cerebral and renal stroke. And again, here is reported just one likely pathogenic variant. So I think that it's very important as we to evaluate this patient, but recent studies just demonstrate that sometimes it's difficult to find the second hit. So maybe most of these patients actually have a second mutation, second virus in the gene, but we cannot find it. So this is the case of the children from Genoa, and Roberta in the end told me that at the end they find a second hit. So maybe when we are convinced that the patient have a clinical symptomatology that is consistent with the disease, of course we have to recheck the genetic test and maybe check the enzymatic activity to confirm or not the disease. Well, we have gone through these, the slide was not like this, but anyway, we have already gone through this work several times in these 2 days, and maybe data 2 is much more frequent than what we expected, and I will not go through it again, but anyway, what I want to underline for you is that despite some mutations, well, there are the missense in vitro missense mutation just affect the enzymatic activity in a very different way. So we have the whole spectrum of affection. And as you can see here, the mutation our patient carried actually was just here in the lower limit of healthy control. So which was the pathogenic role of this mutation. Anyway, some of the patients, particularly with predicted loss of function mutation, have enzymatic activity lower the healthy control range. So this brings us to ask some questions. First, we have shown that heterozygous carriers may show disease signs and symptoms milder and at a later older age. It may be difficult to find the second ADA2 mutation with conventional genetic analysis. So the enzymatic residual activity may help in the diagnosis of patients with negative or not confirmatory genetic tests, even we know there are a lot of variants of unknown significance we have to face in this patient, and that carrier of a predicted loss of function variants display residual plasma activity levels below the lower limit. So this was the question we have already. Should we treat this patient? Not all, of course, carrier patients, maybe those with the classical symptoms or with the reduced ADA2 activity. I mean, is something anyway we have to face. Our patient, we cannot assure that the mutation has any role in the exitus of this patient, but anyways had some clinical characteristics that were overlapping with the homozygous patient, because he had hypogammaglobulinemia as well, and he had this hyperinflammatory syndrome. I don't know if you think it might have been contributed to somehow to the exit of the patient. So I think it's very important and to understand, and we will do some registry, and I am sure that everyone will contribute with his effort to understand better which is the role of heterozygous patient disease. And thank you.
All right, well, thank you very much for that very thought-provoking presentation. I'm sure that there are comments that people may want to make. Yes.
Actually, just a question. How often do we know now that it happened that we found a second mutation in a patient that was first only known to have one allele affected? So I know that the implementation of the studying of copy number variation has yielded diagnoses in difficult to diagnose patients, but I just don't know in how many of the DADA2 confirmed patients we had a single allele affected, and in a couple of years later only we found the second allele, so as you presented. So do you know how often that happened, or does Natalie know it? Or?
Well, actually, I don't know how often it does happen, but maybe when I am.
I have a comment to your question. I think we are very lucky that there is a biochemical test. So that, you can test, even in carriers, whether ADA2 activity is low or not, and then that should be also something that would suggest whether you should treat these carriers or not. But, you raised the question whether we should look for the second mutation. Yes, there are very few patients where we found a copy number variation or maybe variant in the upstream, regulatory region of this gene. But think about what Isabel Mates yesterday said, Should we be looking, for example, for variants that affect the binding of GATA2? Should we be looking in variants that are in GATA2 transcription factors? So basically, there is no monogenic disease. All these diseases are complex because there is influence of so many other genetic modifiers, environmental factors, etc. So not finding a second mutation in the ADA2 gene locus, by that I mean not just coding, but non-coding, regulatory, or whatever, these patients can have another allele someplace like a GATA2 or some other gene which would regulate the expression of this protein or gene. And so that's why biochemical test is important. So
yeah, actually what I have to say, I forgot to say, is that we actually didn't expect this patient to have DADA2 at the beginning. because having said that, despite they didn't refer any consanguinity, actually, the parents did come from a small village in Italy with 700 inhabitants and carried the same surname. So it was suspicious to us. So at the beginning, the genetic analysis we performed, actually our colleagues from the other hospital performed, was an NGS with 49 genes regarding inborn defect of immunity, because it was suspected more like hypogammaglobulinemia, lymphadenopathy, so it was not expecting DADA2 because the inflammatory component was not that clear at the beginning. So I think that this indeed broadened the spectrum of the disease. Again, we have to think really about DADA2 patients in different settings.
Well, one comment that I would make on Ivona's comment, certainly it is the case that all of these diseases are, at least to some extent, complex. I mean, you know, for sure, the rest of the genome does have a role in terms of determining penetrance of variants and the genes that we're interested in. I do, though, want to just, so that we don't forget the conversation that we had with regard to the possible lysosomal function of ADA2, that even though we have a biochemical exam that tells us something about enzymatic activity under certain circumstances, that may not be the whole story with regard to you know, what's going on with ADA2. You had a comment or question.
I also just want to bring up the cell source that we do our genetic testing from, because there's probably a small portion of patients who may be mosaic, and if we're not looking in the cell types that are, you know, most meaningful to the phenotype that we're seeing, we may be missing it if they're mosaic.
Yeah.
Yeah, I mean, mosaicism has been described in several autoinflammatory diseases, so it might be even the case in DADA2, of course, but actually we don't know if it somehow has contributed to the phenotype of the guy, but and it's difficult to say because it was post-mortem, the analysis, so, but I would like to know what Paul maybe think about this.
I don't know what I think. There's no point.
Sorry?
What was the month in the year that your patient died with hyperinflammation, a bit of hypereosinophilia, and pleural pericarditis? 'Cause we've kind of been through a pandemic where quite a lot of patients died of that, from hyperinflammation post-COVID.
No, it was much. It was previously the pandemic. I mean, yeah.
Well before.
Yeah.
Okay, good.
Yeah. Well before.
All right, any other comments or questions? All right, if not, I'm sorry.
I just wondered if in your patient with the DRESS who had just one mutation, could there be like one genetic HLH mutation and maybe the two things in combination? Because I thought it was interesting. Mandy mentioned a patient yesterday with one ADA2 and then one Fabry's, a female with Fabry's, which is unusual, and they're both lysosomal. So you wonder, rarely maybe carriers can have an impact if they have two kind of hits in some way?
Well, yes, actually I'm not aware because it was performed in another hospital of all the genes that were analyzed. Anyway, he had this panel for immunodeficiency almost because of the clinical. But yes, actually he didn't have a full-blown MAS. He had higher ferritin and higher triglycerides and lactose-derogenase. I don't know which is the English for it. But anyway, the white blood cell count were absolutely normal, no pseudocytopenia, no anemia. So, and the transaminases were normal. So it was not a full-blown mass, actually. Maybe it was something, maybe, well, a variant might have contributed, HLH variant, but at least it was not clear in MAS.
Okay, all right, well, thank you very much.